Healthcare providers are balancing AI innovation with clinical and security risks as 79% face unmanaged AI use. Jay Tusset of Netanix and Ratanesh Ramasundram of Frost & Sullivan discussed the issue. Welcome to the program, Jay and Ratanesh. So how serious is the risk of unmanaged employee-deployed AI inside healthcare organizations now?
Yeah, I can go with that question first. Before that, thanks for having me. And I spend most of the time talking to systems about how they're actually adopting and governing AI on the ground. And that's the lens I'll bring today. I would call it serious, but predictable. This is less a technology problem and more a symptom of how fast clinical demand is outrunning IT's ability to say yes fast enough so the staff go around them. It's exactly what happens when clinical pressure outpaces IT's ability to deliver a section tools fast enough. And that pressure is real. As APEC is heading toward 11 million healthcare workers shortfall, so staffs are actively hunting or anything that eases the load. In the Singapore context, Singapore has actually moved to close the gap. The MOH, the SHA refreshed the AI in healthcare guidelines earlier this year, and for the first time, it puts clear life cycle long accountability on the healthcare organization itself, not just the vendor. But beyond compliance, what strikes me is how uneven readiness still is. Singapore ranks among the most AI mature health systems globally, while several neighboring markets are still early stage. So the risk isn't uniform even within the same hospital group's regional footprint. The strategic issue isn't just having a policy in place, it's that unmanaged adoption creates inconsistent care quality across departments and sites. And that's far harder to fix after the fact that to get ahead of.
Yeah,
I
well
just would add,
Jay.
yeah, Rotnich is exactly right. In fact, we had done a study recently called the Enterprise Cloud Index for healthcare and determined that 8 out of 10 healthcare organizations determined shadow AI, which is essentially the unmanaged use of
Mhm.
AI within an organization, is prevalent. And of those, 83% recognize that it causes real business risk. You can see how this could work within a healthcare context where it's really not just an IT problem, it becomes a patient safety issue. So if you have practitioners, for example, that are sending data into frontier models, whether it's Google Gemini or Anthropic Claude or others, and that creates real risk both from a data leakage perspective as well as from the perspective that they actually could get the wrong information back and it becomes unmanageable, ungovernable, and there's no way to really report back to how that information was created in the first place because there's no audit trail to it. And so all of those things combined create a real challenge. Now the answer to this is actually fairly straightforward. The reason that people are using shadow AI is because the governed route to AI is too challenging for them to use. And so they want speed, they want simplicity, they want to be nimble in how they're leveraging AI. And so the answer for the organization is actually to create the governed model that is easier to use and deploy than the ungoverned model. And with that, you'll see the rapid depletion of shadow
Mhm.
AI as people go back into the normal models with IT governance.
Mhm.
On that note, Jay, can hospitals rely on cloud-based AI when bedside decisions need near zero latency? Can you go first?
Sure. So, the world I think is not a cloud versus non-cloud dynamic. I think what you have applications and workloads that where both will be required. And so you think about, for example, an ICU bed, the typical ICU bed has 15 to 20 connected devices to it, all of them throwing out data consistently that tie directly to patient health and safety. All of that data needs to be understood and derived meaning from in a real-time basis. And so with that, you really need to have within the hospital applications and edge use cases essentially that are really going to be on premise in nature. At the same time, when you look at the ability to append that with more regional information, with different types of applications and use cases, they clearly will live in cloud. So I think the world is hybrid. I think that there will be use cases and applications that need near to low term latency that will be on premise in the room itself with the patient. And then there will be other use cases where you can actually extrapolate more meaning by consolidating and aggregating data within clouds. And I think both will be used.
And Rathanesh, do you agree with Jay?
I absolutely agree with Jay. I believe hybrid is the key term here. For example, integration of edge, core, and cloud. I'm sure Jay is more familiar with these terminologies. So the time critical bed-size inference, the real-time decision support in an ICU increasingly needs to run locally at the edge or on-premise, public or private cloud, because milliseconds matter here, right? And connectivity isn't always guaranteed. Heavier workloads like model training or population health analytics are still well suited to the cloud. What interesting more from a market perspective is that the APEC healthcare AI market is still in a steep growth curve. And the health systems pulling ahead are the ones treating infrastructure architecture as a competitive differentiator, not just an IT decision. In Singapore, for instance, right, already runs shared national imaging platforms that triage tens of thousands of cases a month in seconds. Now, that only works because the latency sensitivity layer is engineered deliberately, not left to whichever cloud happens to be available, right? So the providers who get ahead here are the ones who stop treating our infrastructure as background plumbing and start treating it as part of their clinical strategy.
Now, this may be a lot to take in one go. So, if you were to make recommendations, where should providers modernize first? Is it infrastructure, governance, or more on the frontline workflow? Ratanesh?
Yeah, so it's not a straightforward answer here, right? In my opinion, having interacted with health systems at very different stages of maturity across the region, this really depends heavily on where a provider sits on the readiness curve. There's no universal answer, as I said. A highly matured system like what we see in parts of Singapore can move faster on higher stakes AI backed by strong governance and cloud infrastructure already in place. What I would caution against here is over indexing on either extreme. Infrastructure first projects can take a year if before anyone sees the clinical value, while workflow first projects without governance guardrails are exactly how we end up back at the shadow AI problem where we started with. The pattern we consistently see across APAC health systems is small, covered pilots that earn trust and evidence, then scale into broader infrastructure investment, not the reverse. Again, here, what I would tell any provider, regardless of maturity, is to resist the urge of modernizing everything simultaneously. The health systems that stall are usually the ones trying to fix infrastructure, governance, workflow all at once instead of sequencing deliberately based on their starting point.
And Jay, go ahead.
Yeah, I think, as we discussed earlier, the world is hybrid, and modern hybrid environments support secure, low latency AI workloads from the data center, from the hospital, from the caregiver, all the way through to public cloud. And so when we talk about modernization, especially around infrastructure, there's so many different avenues and routes and paths to get there, depending on what you're actually trying to accomplish. And so the three elements that you just described, I would argue, go hand in hand. You can't do one without the others. So ultimately, frontline workflow is the payoff. That's where the value will come for the actual care provider. But you really can't do that if you haven't modernized infrastructure in the first place and you don't have governance to guardrail the application itself. As you start looking, for example, at agentic applications, which will play a core role in healthcare moving forward, the risk of an agent is only as great as the data it has access to. And so that comes essentially with governance. And so if you want to look at opportunities to really modernize quickly, and do that in a manner that drives the best value for the organization, it comes down to doing it in conjunction with governance so that they happen together. Governance means a number of different things. That means cost governance, it means security governance, it means sovereignty governance, making sure that all of those elements are in place so that as the actual workflow delivers value to the organization, as AI is embedded into daily care delivery, that those guardrails are in place so that the application itself is supported. But none of that works if you haven't modernized in the first place. And so I would argue that they go hand in hand. You really can't address one without the other.
Yeah.
Thank you so much for sharing your thoughts, Jay and Ratanesh.
Thank you.
Thank you.
Once again, those were Jay Tusat, the Vice President and General Manager for APJ at Nutanix, and Ratanesh Ramasundram, Head of Healthcare and Life Sciences Asia Pacific at Frost & Sullivan. For more news, visit sbr.com.sg.